Hi everyone. Thanks for tuning into the UWA Surgical Society Women in Surgery Educational Series. My name is Davina. I'm an MD3 at UWA and the current UOS Women in Surgery Chair. We're excited to bring you this surgical rotation crash course, prepared and presented by Dr. Helen Ballal. Dr. Ballal is a general surgeon at Fiona Stanley Hospital, having completed her surgical training last year. She received her medical degree at the University of Newcastle upon Tyne, before completing her basic surgical training in Liverpool. She then began research at the School of Cancer Studies at the University of Liverpool, evaluating the biological pathways of responses to chemotherapy in breast cancer, which she finished in 2018. She's planning to specialise in breast and endocrine surgery. Now, over to her to give us some tips for making the most of our surgical rotations.
So hi, my name's Helen. I'm one of the fellows at Fiona Stanley, and I'm just going to give you a brief overview about how to make the most of your surgical rotations. So your surgery jobs will be your most fun attachments. You'll always get lots and lots out of it, but they can be physically, mentally, and emotionally challenging depending on what's going on. You need to be prepared for long days. It's not your 9 to 3 days. And with the rotations, you're in early and some days will finish late. And you need to have a bit of a plan for your theatre days to help you get through these. So there's 3 main areas you'll be in with your surgical attachment. There's the theatres, outpatient setting, and then also what you can do to make the most of your time up on the wards. So in theatres, the first thing to do is just try and get a tour of the theatre suite. And often the theatre coordinator will do this for you. You want to know where the changing rooms are so you don't feel quite so lost on the first day. Find out where the scrubs are and make sure you know where all the sizes are. The theatre scrubs are normally colour coordinated, so if you can work out which colour scrubs you'll feel more comfortable. Sometimes they'll have lockers for students, so certainly the nursing students always seem to have some lockers, not so much for medical students, but if there isn't a locker, then you need to keep your bags with you. The changing rooms are not great places to leave valuables. But again, often you need to ask. They will forget to tell you where things are. The next thing is to go and find where the front desk of the theatre is, and all the main hospitals have the front desk, and there's always a whiteboard there, and it tells you who's in which theatre. So they all have the theatre numbers across the top. They have the name of the surgeon and the speciality, and often the name of the anaesthetist as well. And you can work out which actual theatre you are supposed to be in if you know what surgeon you're going to be in. Next area to get to then is to go to the pre-admission area. And this is where patients are booked into theatre. And they normally go into the bays according to which theatre they are going to be in. So again, have a look at the whiteboard. It'll have your patient name, which theatre they're in, and then which bay they are in the pre-admission area. This is where the notes will be kept if it's a hospital with paper notes. It's where the marker pens are, and there'll often be screens up there so you can have a look at some x-rays and things before you go into theatre. When you go into theatres, there's usually set up in different areas. So you've got your emergency theatres are normally together. You have your general theatres, or orthopaedic theatres. There'll sometimes be a robotic theatre. And then interventional theatres where the vascular surgeons do those their procedures. And in Fiona Stanley, there's a hybrid theatre, which is half open and half interventional. So you can do open and interventional procedures together. And they're all set up a little bit differently. So try and get your head around where you are so you know which general area you want to go into on your first day. It's always good to know where the toilets are in case you need to nip to the loo in the middle of the day. Otherwise, you have to go all the way back up to the changing rooms. And there's usually a couple of toilets around the theatres, so have a look out to where the closest ones are to the theatre suite, so you're not having to walk far away to get to the toilet during the day. Next area of theatres is the PACU area, so this is where patients go post-operatively, and that's always good to go and see, to know what we're checking for post-operatively, see how your patient's going, checking the wounds, checking the drains, and just seeing how that area goes. And by and large, on your surgical attachment, you don't spend a lot of time in PACU, but it's often worth going to see what your patient's going through afterwards. So it's a good area to go and find out some tips. It's good to learn about post-op analgesia. The nurses there are normally quite experienced. There's always a tea room, so it's good to know where that is and know where the tea, the coffee, and the milk is. And there's often a doctor's room as well, where there'll be some computers. You can check the notes, you can find out what's happening, look at the results for your patients up on the ward. and that's often a separate area. So these are the areas to try and work out where they all are in your first day or two in theatre. So the next part, being prepared, is making sure you've got everything ready so you're not getting told off by people for not having the right stuff on. So scrubs, like I said, they're often colour labelled, usually range from extra small to XXL large. Please don't wear them home. You will get caught wearing them home and you'll be told off, and it's always messy and it's just not clean. So don't take them home with you. And a lot of the hospitals, they don't like people to wear theatre scrubs when you're on the wards or in clinics and on theatre days, despite the fact that you see everyone else walking around the hospital in scrubs. It's not really the best practice to do, and it just saves you getting in trouble with senior staff. Yeah, so just try and stick to the theatre scrubs when you're actually in theatres. Some hospitals, Fremantle for example, will ask the medical students to wear disposable scrubs if they've got lower numbers of scrubs. So just, again, always have a look for the signage around and make sure you know which ones you need. If you get dirty during the day, then just change. There should be spare sets. If there's low numbers of scrubs, it's normally early on in the day, and then they all get replenished as the day goes on. So theatre hats, to be actually in the theatre itself, you always need to have a hat on, and it's very easy to walk in and forget to put your hat on, but you'll get told off for that. When you put your hat on, you want to make sure all your hair is covered. Some hospitals will let you wear cloth hats now, but not all of them. Fiona Stanley will let you wear cloth hats now, Walperth doesn't. I'm not sure about Charlie's at the moment, but just, again, make sure that you know the rules. And if you are going to wear a cloth hat, make sure that it's clean and you wash it every day. Some hospitals have a colour code to the hats, where the coordinator, for example, will wear a red theatre hat. No one else is allowed to wear the red. So it's always worth having a little check to make sure there's no colour code and you're wearing the right one. It's really important to wear comfortable shoes. They need to be supportive. They need to be comfortable because you're going to be standing for a long time. You need to have enough coverage for your so there's no holes in your toes. The Crocs with the holes in, you'll get wet feet. The floor gets slippy with all sorts of stuff, so you need to make sure that you're not going to slip on the theatre floor. You want them easy to clean, so when they get covered, you can clean them. And you probably want to bring some spare socks as well, because quite often your socks will end up a bit damp too. Try and remember to bring your own pair of shoes with you. There's not usually spare theatre shoes in theatre now. And if you are wearing an outside pair of shoes, there's usually some blue coveralls for your shoes. So make sure you're fully covered if you've got outside shoes on. When it comes to jewellery, again, it's best to avoid it if you can. So necklaces, earrings have been known to fall into the patient, so you're asked not to wear those. You have to wear your rings when you're scrubbing, even your wedding ring. So it's best to just not bring them if you can. If you are going to wear your rings, and I do wear my rings during the day, then you just need to have somewhere safe to keep them. They'll fall out your pockets. Lots of the scrubs will have holes in the pockets, so you don't want to be losing them. And there's more than one surgeon has thrown their wedding ring into the scrubs at the end of the day. So you can use the clip on your badge to put your rings on so you don't lose them during the day, or you can get a safety pin and put your rings on a safety pin and pin it to yourself. That keeps them nice and safe. If it's a wedding or engagement ring that you don't want to leave at home. But everything else you should try and leave at home, and you will be told by the theatre sisters off for wearing them. All right, so the next part of being prepared is you've got to look confident and look the part. So Lombardi was a surgeon who basically said, if you turn up on time, you end up being late. So you've got to be at least 5 minutes early and make sure you're there before the team. It never looks good if you walk into theatre 5 minutes after the huddle. So most of the time you'll do a theatre huddle at 8 o'clock for morning lists, 1:30 or 1 o'clock for afternoon lists. So find out what time you're expected to be in theatre and be there 5 minutes early, waiting for people rather than walking in halfway through the preamble for the day. When you come into theatre, be confident, introduce yourself to everyone in the team. Remember, there'll be the surgeons there, and anaesthetists, anaesthetic techs, nursing team, orderly, sometimes there's reps, and try and get a feel for who everyone is. Good practice is to have everybody's names on the whiteboard in theatre, And it's good practice to go and write your name on the whiteboard so the nurses can put it in the computer, and you put that you're a medical student, and you can put with the surgical team or the anaesthetic team and what year you are, and then everybody knows who you are, everyone's interested. If you've got a name badge, you should wear it on your scrubs again so people know who you are. And the next thing you do is to be noticed for the right reasons. So you shouldn't have your phone out in theatre. It should be in your pocket, it should be on silent. There's enough phones ringing in theatre that shouldn't be without the medical students going. If there is a locker there, you said you should have your bag in there, but if not, don't leave your stuff in the changing rooms, bring them down with you in your bag, and ask the theatre staff where you can put them. The floor isn't normally a good idea, but often there'll be a little tray or a table where you can leave your bag. Your clothes and your shoes are usually okay in the changing rooms. But yeah, I wouldn't leave anything viable in any of them. And then join in the huddle, introduce yourself. And if you know something about the patient that has been missed, you think is important, feel free to speak out. The next thing to make the most of what's going on the list is to know what's going on. So there's ways to find out about what's going on in your elective operating lists. There's a list with the secretaries, list with the waitlist office or on TMS. Find out from the juniors in the team what's on the list for the next day or the day that you're scheduled to be in theatre. And then read up on the operation. There's only so many questions can be asked about most things. You know, you're going to get asked some anatomy, so think about if you're going to watch a right hemicolectomy, find out the blood supply to the right side of the bowel. Are there any important nerves there? What are the surrounding structures? These are the type of things you're going to get asked and that you should be looking out for. Have a think about why the operation is being done, and have a read about that pathology, because you're going to get asked about that, and you'll get much more out of it if you know what you're expecting to see and why you're going to see it. If you can read the operation, you're not expected to know in detail, but if you can think about the sequence of events and you can anticipate what's going to come next, it's much easier to stay alert, particularly during a long operation, if you can anticipate what's coming on next. Then you won't miss the important step, and you'll know what's going on. It's easy. It's much easier nowadays. There's almost every operation you can think of is available on YouTube, or in the surgical library will have videos, so always have a look at your med school library. And watch the videos and know what you're looking out for beforehand. So as well as about the operation, they have to think about the patient. So if they've got electronic records, it's very easy. You can have a look at the letters beforehand. Paper notes can be a bit harder, but if you know you're going to the list, the paper notes will usually be in the pre-admission area the day before. So try and get up the afternoon before the theatre, have a look through the notes, have a look at any imaging. If you know that there's some lesion in the bowel or something in the adrenal gland, get them up and have a look. And if you can't see it, then ask the registrar to show you that day in theatre. So I had a look at the scan. Could you please point out the lesion to me? I couldn't see it. You never really get taught how to look at the scans as a medical student, I found. And you get the most out of it just by looking at more and more and more scans and working out what's normal and what's abnormal. And then it slowly all comes to you. It's really nice to go and talk to the patients beforehand. So again, if you've read something in the notes about the patient being anxious, you can always check with the registrar the day before. Is it okay if I go and see the patient? But otherwise, there's nothing to stop you just going and saying hello to the patient and just introduce yourself. Hello, I'm a medical student. I'm going to be observing your procedure today. Can I ask a few questions? And try and, depending on how much time you've got before the procedure starts, you can just take a history presenting complaint, you can do a full history. And it's not unknown for medical students to take a better history than some of the junior doctors. We had a case about 18 months, 2 years ago, where supposed to be having a large bowel resection, and the medical student picked up on the critical leg ischemia. So we cancelled the patient on the day. And if we hadn't, he would have spent a long time in a head-down procedure and probably lost his limb. So it's important, if you identify something and you think it's important, then mention it to somebody. You're part of the team. Okay, the next part is about scrubbing. Now you all get talks about scrubbing and you get signed off on scrubbing at CTEC, but if you don't feel confident, then ask either one of the junior doctors or one of the nurses if they can take you through the first scrub of the day. The first scrub of the day is 5 minutes, and it always takes longer. So one thing you can do while you're there being early and being prepared for the list is do your first 5-minute scrub before the list starts. So that when you come to scrub into the case, you only have to do your 90-second skin man or 3-minute scrub. It doesn't really matter if you're using betadine, chlorhexidine, or the alcoholic skin man, but if you use the same one all the day, throughout the day, it works better and you get a curative benefit from that. So it doesn't matter which one you use, but stick with the same one. The next question is, how long do you scrub? And the answer we always got told is 30 seconds longer than the senior you're scrubbing with. And if you don't do it properly, the nurses are watching you guys like hawks, and they'll make you stop and start again. So always, it's really important that you do scrub properly. If you think you've contaminated yourself during the case, it's really important that you say and unscrub and rescrub back in. It happens to us all the time. So if you're ever in any doubt, just unscrub and rescrub in. The gowns normally are large, extra large, and XXSL. So again, it takes you a little bit of time to work out which one's best for you and most comfortable. But if you know there's a size you prefer, then that's the size you should get. And it's a good practice to open your own gown before theatre. But again, get the nurses to watch you the first few times to make sure you don't decontaminate the whole gown and gloves trolley. When it comes to glove size, again, it can take a little while to work out what size gloves you want. It's good practice to double glove, and everyone should get used to doing that. And the same as when you're starting to tie knots at home and you're doing your practicing gloves and practicing double gloves as well. It's very personal what you do with the double gloves. Some people like 2 sizes the same size. Some people like half a size difference and they wear the bigger size on top or the bigger size underneath. There's no right or wrong. Again, you just have to try a couple of combinations until you work out what's best for you, and then try and remember it. Undergloves are usually blue or green, and that they're indicator gloves. They'll show you if you get a breach in your top glove. And just always be aware if the patient's got a latex allergy, you have to use the latex-free gloves. They'll normally be first on the list, and it'll be talked about in the huddle. Commonest mistake I think the medical students made is they forget to put the eye protection on. So there's, your normal glasses aren't sufficient enough and they don't meet the occupational health requirements. But there's usually either plastic pairs of glasses around, hoggies, you can find around the glove trolley, or you take a visor with the mask. But it's really important that you do wear eye protection, and you have to put your own on before you scrub. It's really hard to have someone put eye protection on for you once you're scrubbed. It's nice to be able to stay for the whole case, but we know that you can't, and you've got tutes and lectures at all different times of the day. So you're not expected to stay for the whole case. But if you know you're not going to be able to stay for the whole case, then just make sure you let the surgeon know beforehand that you need to go and what time you need to go, and step out at an appropriate time. Like I said, days can be long, so make sure you're fed and watered. Have a breakfast, particularly if you're having a long case. If you've got a day with lots of little cases, or you've got a long case and you're going to have a lunch break, bring some snacks with you, have your lunch planned. If you're only going to get a 20-minute lunch break, you don't want to spend most of that in the queue downstairs for a sandwich. You'll try and bring it with you. There's a lot of standing around, and sometimes that can get very hot. You are in scrubs, you're in lead aprons, you're in gloves, masks, the hot lights, the bear huggers are on, lots of hot air. So make sure you drink plenty and think about putting some compression socks on. And if you're going a long case, like I say, go to the loo beforehand. That's why it's important to know where your toilets are close to your theatre. Think about how you're standing. It's a long time and a long career to be in, and you've got to protect your neck and your back. So bend your knees, stand on your tiptoes. If you can't see, there's stools to step on. And just be really mindful if you're doing something there to have the table to your height. Sometimes you can get quite tired, particularly if you're holding a retractor, you're a long, boring bit of the operation, there's no next step to be following. But what's really important is not to lean on the patient. So quite often, if you're especially down the other end, you'll find yourself leaning on the patient's legs. You'll give them an increased DVT risk if you're stopping the blood flow. So you have to be mindful not to lean on the legs. mindful of the anaesthetic tube, and remember the face is usually covered, and it's easy to forget that there's a person under there when you're just looking at one bit. So just be very careful. And the other thing is, you know, sometimes it gets quite smelly. So if it's a bit smelly, breathe through your mouth. And we want you to be involved. You'll get much more out of the operation if you're involved. There's often bits of the operation you can do, the draining of the abscesses, the closing of the skin. So we want you to be active and dynamic, member of the team. It's important to move about during theatre, but you've got to balance that with not getting in the way. Sometimes you can see from previous cases where you've not been scrubbed, or you've seen what's going on, like where people have stood. And you can work out, you know, what your role can be. What's quite nice to do sometimes is to walk from the holding bay to the theatre of the patient. When you finish taking the history, you can have a chat with them round, and that helps put the patient's mind at ease if they've just had a nice talk to you, and let them all know the history. Once the patient's asleep, it's good to help with the positioning. There's, especially with the bigger patients, you know, many hands make light work. You can help put the legs up, you can put arm straps on, there's bear huggers to put on. The patients will usually need IV lines. The anaesthetists are the best people to learn from putting lines in. So even if you're with your surgical rotation, if there's no medical student with the anaesthetist, get them to show you how to put the lines in, put some lines in from them. When you're learning to do catheters, the best time to do it is when the patient is asleep. You know, it's much more comfortable doing it when the patient's asleep than when they're awake on the ward and they've got a large prostate and you're a bit nervous because it's your first time. So again, the nursing staff, the junior doctors are always very happy to talk you through the steps of putting the catheter in, and you can get your first couple out the way at that time. There's often blueys to be put down. You can put the calf pump on. You can look at where the diathermy pad goes. You can learn about not putting it over where the metalwork might be. And when you come to do the timeout, the nurses are always looking for someone who can help read the band. So there's lots of little bits you can do that will help and really make you a part of the team rather than being someone standing in the background, not really joining in. So general etiquette in theatre, if it's blue, it's sterile. So you can only touch it if you're sterile, and if you touch it unsterile, then everything gets decontaminated. So the best place to keep your hands is clasped in front of you at chest height, and rest on table when you can, because it gets quite tiring holding your hands up here at this time. A lot of people will fold their arms, but you can quite easily decontaminate yourself at your back there. So try not to get into that habit, although you'll see lots of surgeons doing that. Like I said before, if you think you've compromised the sterility, speak up. It's much better to sort it out than not. Sometimes people will tell you you've breached sterility and you might not think you haven't. It's just easier to unscrub and then join back in. When you are scrubbed, you can ask the surgeon where they would like you to stand. And if you can't see and you're scrubbed, ask for a stepping stool. There's lots in theatre. It's, you know, there's no point in being scrubbed if you can't see, and the easiest way to do that is to stand on a step and someone will get you on. Never touch the nurse's trolley or the Mayo stand with the instruments on unless you're asked to. And if the surgeon's asked for an instrument, sometimes you really want to be helpful and, you know, take the instrument off the nurse and give it to the surgeon, but try not to do that. It should always be the nurse handing the surgeon the instrument directly. If you want to ask for something, or you want to ask the nurse something and they're doing a count, don't interrupt them. They will never like that. Always let them finish the count, and then they can get to you what you need. And when you're retracting or doing something, especially with the first few times you're seeing an operation, it's best not to be helpful at those times. That's when you just follow the instructions. You hold the retractors where you're given. Don't move them unless you're asked to move them. So unless you know what you're doing, you're very confident, it's best just to follow instructions and try not to be helpful, otherwise you'll find you'll move it just at the wrong minute. And finally, if you do feel faint, and again it happens to all of us, you know, then do speak up. We don't want you falling and hurting yourself. We don't want you falling and contaminating the patient. And the best thing to do is usually just to sit down with your back against the wall and take the mask off and have a drink of water. But speak up before you get to that point. Like I said, it's happened to everybody. And so yeah, we want you to be a good assistant. So we want you to be involved and not just standing back, not able to see. You have to be able to speak clearly. It's very hard sometimes with the mask on to hear what's going on. So if you want to speak, make sure you are audible and not mumbling. And it's hard to go wrong if you're just doing what you've been asked to do. When you are holding the retractors, swap hands if you can, without changing it, without changing the position of the retractor. It's easy to get fatigue and cramps. If you're holding a retractor and it's not being used, then relax, pump your hands. You'll be asked to cut the sutures, and with the normal joke is you want to cut them too long or too short, you'll never quite get it right. It doesn't really matter, it can all be fixed, just not the knot. You can be asked to follow the suture, and that's important, particularly for things like vascular surgery. You have to keep the tension that is given to you. That's a skill to learn. And the other thing you can do is you can develop a steady hand for laparoscopy. And if you're being asked to hold the camera in a case, the key tip is to try and keep the instruments in the center of the screen, and then anticipate the steps of which way you are going to be moved. Sharp safety is very important in theatre, so the sharp should always be given in the kidney dish. Guard the needles before they get back them, and vocalize that the sharp's back to you. And just make sure you know what the local needle stick policy is, or who to ask about the needle stick policy if you do unfortunately get a needle skip. At the end of the procedure, just at the end, you don't unscrub until everybody else do, because sometimes it's just the one extra dressing or something to put on. When you have unscrubbed, help get the patient back on the bed and say thank you to the theatre staff, and you will be more than welcome to come back again and enjoy the day. The other thing to remember is that all surgeons differ. Sometimes you'll be in theatre and everyone's having a great time, the music's playing, and everyone's having a bit of a giggle. Other times you walk into theatre and it's very tense. And you have to be able to read the atmosphere in the room. Sometimes it's just that something may have happened on the wall beforehand. It could be a very particular point of the operation. Something could be not going very well, and it's best not to ask about it at that time. So you have to just be a little bit mindful about how the atmosphere is in the room, how are the juniors behaving, how the consultant, how's the anaesthetist behaving. If the tension suddenly changes, so the music's been on, everyone's having a good time, and all of a sudden the music's been asked to switch off, everyone's a bit more stressed, a bit more focused, then you just have to react appropriately to that. And it's not a good idea to ask them if that much blood is normal, if the bowel's supposed to be black or anything like that. Just be a bit mindful. Surgeons vary on how much conversation they want during the operation, and sometimes it can feel like they're being a bit harsh, but some people just like to concentrate on the operation. It's all surgeon by surgeon, case by case, and again, it's a little bit of picking up. Sometimes, unfortunately, you just have to err on the side of caution, and it sounds a little bit harsh, but just speak when you're spoken to in those atmospheres. And then, as with everything, there's good times and bad times to ask questions, but mostly that's what you're there for. You're there to learn. If you want to ask a question, but you feel it's not quite the right time, try and remember it and ask at the end of the case, or write it down, or when you're discussing the case the next day or on the round later on, then ask about it then. Never not ask the question, just think about the best time to ask it. And yeah, again, music's normally a good atmosphere indicator of what's going on in theatre. And then at the end of the list, usually there's a post-op round where you go and see the patients you've operated on, check for early complications, sorry. So if you've got time to hang around for that, then you can do, but it can often be quite late in the day. It's often 6, 7 o'clock. But the things you've got to think about is what you're going to go and look for when you go and see them post-op, and think about the fluid balance, the painkillers, there's the DVT prophylaxis, the flaps viable, the bleeding, swelling, what's in the drain, how much is in the drain. These are all important, immediate post-op things that you can look at and be aware of. The next place you'll find yourself is on the ward. And the ward can be a little bit variable. You can go between business rounds where you just got to crack on, see the patients, get to theatre, get to clinic, or more the grand round, teaching rounds, where you've got time to go around and do some teaching at the time. Try and have ownership of your patients. A good practice is to either allocate yourself a couple of patients on the ward, or ask to be allocated a patient. So either someone you're going to go to theatre with, you've been to theatre with, you've met in the outpatient clinic, and you can know those few patients' history really well. Keep the juniors up to date with the changes, have the lists printed early, have the blood results ready early, so all this information is to hand for the ward round. And if you're checking the bloods for your patient and you notice there's some abnormalities, then let the interns know, because maybe you've checked beforehand, and you can get that potassium fixed before the next day. So the time to be checking the bloods for your patient is not the next morning before the ward round. It's at midday after the morning phlebotomy round, so that things can be corrected and picked up on. So it's all about just being organised and knowing everything about your couple of patients. So when you're doing the business round, it's good to know your patient. So the status is good. So example, day 3 post elective right hemi. When there's a couple of you on the ward round, it's good to have different roles. So you can have somebody typing in the notes, somebody's going to check the observation chart, somebody can check the drug chart, look for the antibiotics, look for the post-op DVT prophylaxis. And if somebody's doing all of those, then the round will go smoothly and everybody knows what they're looking for. If you've been tasked with doing the scribing, it's not just cutting and pasting, particularly with these electronic ward rounds. You've got to think about what's the new thing for today, what's the change, what's the plan for the day. Is there somebody who's waiting to go home? What's the thing stopping them going home? What do we need to move on? What was the change? Has they've got a temperature that we were not expecting? Are we waiting for the bowel function to come back to normal? If you've been tasked with looking at the observation chart, it's not just that the obs are stable, because they might be stably bad. What you want to know is that, what's the temperature? Is there any tachycardia? How's the blood pressure? Have a look at the fluid balance chart. Have a look to see if they're eating. General surgery is important to look at the stool chart. And the same with the drug chart. It's not just about looking at it, it's about looking at it and thinking about it. Are they on antibiotics? Do they need to be on antibiotics? Can they be stepped down from IV to oral? Can they be stopped? Have they been using a lot of post-op analgesia? Is it increasing? Is it decreasing? And also you can have a look if they've had a drug rec from the pharmacist. Is there anything that they should be on that they're not? And on the business order, the next important thing to look at is the IV fluids for the day. The best time to get those done is on that time when you can ask questions about whether they still need fluids, what fluids do they need, how is the renal function, what's their electrolyte balance, and that's the time to be doing that. Lots of skills to master on the ward, and you can help the interns and the RMOs with this. So again, you can learn catheterization if you haven't been able to do it in theatre. The nursing staff here are amazing at putting NGs in and taking them out. But if you get a difficult one, they're going to ask you as the intern to come and do that. And if you've never done one before and you're only being asked to do the difficult ones, it becomes hard. So if you know someone needs an NG tube putting in or taking out, go and volunteer to do it, ask the nurses to take you through it, get the other interns to take you through it. The more you do, the easier it is to become when you get asked to do the difficult ones. Try and get as many cannulas in as you can, take as many bloods and blood gases as you can. Have a look at the different types of drains. If somebody needs the clips removed from the wound, you get someone to show you how to do that. If someone's having the wounds dressed or packed or unpacked, get involved in all of that, because these are skills that you'll all of a sudden be expected to do as a junior doctor and nobody will ever show you. The nurses are an amazing skills resource and they're always more than happy to take you guys through it. So, get involved and ask them to show you. And when you're on call, on calls, it can be difficult. Sometimes you can be very busy and get lots out of it. Other times it can be a bit quiet. So just be a bit organised and bring your books with you for the quieter periods to make the most of your on calls. Outpatient clinics are useful as well. You'll either see new patients or follow-up patients. So know what type of clinic you're going to. If you're going to the colorectal clinic, you need to know about the signs of bowel cancer. What are the red flags for bowel cancer? How are you going to follow up somebody who's had a bowel cancer resected? What investigations would they have? If it's a new patient clinic, as well as thinking about the presenting complaint, what factors do you need to think about for their fitness for surgery? So think about being able to take a focused history and what are the things you can get out of that clinic. There's often procedures to master in outpatients as well. You'll do rigid sigmoidoscopies in the colorectal clinic, ENT in the endocrine clinic, or could be shown how to do nasal endoscopy. The breast clinic, you can be shown how to do punch biopsies. So there's lots of things going on to get involved in. So just either ask or make sure you can mention at the beginning of the clinic, if you're doing anything, can I come and see? Sometimes you will sit in with the registrars or consultants. Sometimes you can take your own history. It all depends if there's a room available, and then present the case. And like I said, think about if you're seeing follow-up patients, why are you seeing them? Was it because of complications? What complications? So think about how you're going to take that focused history. So it's quite busy, lots to take it on board, but I think most importantly, it's a fun specialty. You'll get lots of skills out of there. Most of the surgeons love having medical students around, love having keen, enthusiastic medical students around. We love it when it's obvious you've done some reading beforehand and you ask the relevant questions and you show some interest. It makes it much more worthwhile teaching somebody who has some enthusiasm. You'll see a very different side to most of your bosses in theatre than what you do on the ward, so that's always nice to see. And the other thing to remember is, even if you don't want to do surgery, or if you decide surgery is not going to be for you, most common surgical procedures are common. You know, there's a huge number of the population have had their gallbladders out, have their appendixes out. Most people will have broken a bone at some point. So you'll come across them no matter what specialty you're in, and it's good to know what they've been through, what complications they may have had, you know, why they may have had the complication that they had. So it's much easier to understand what's been involved in your particular patient's care if you've got an idea of what's going on. And mostly you get out of surgery what you put into it.